Thank you, sir. Now, moving on to the next speaker for the day, Dr. Josna Jose ma'am. Dr. Josna ma'am is a highly motivated and patient-focused clinical pharmacist who completed her PharmD from PSG College of Pharmacy in Coimbatore. She is a dedicated healthcare professional with a commitment to optimizing medication therapy and collaborating with other healthcare professionals to ensure best possible patient outcomes. She holds professional licenses from the Kerala State of Pharmacy Council and DHA license. Her professional experience is varied and expertise. She is currently a clinical pharmacist trainer at ICRA International Hospital in Calicut, Kerala. Ma'am has worked as a pharmacist at Asta Pharmacy in Dubai, where she was responsible for controlled medicines management and pharmacy operations. Prior to that, she served as a pediatrics clinical pharmacist at Baby Memorial Hospital in Calicut. In this role, she conducted rounds with physicians, presented medication recommendations, provided drug information, and developed antibiotic dilution and infusion protocols. She was also a member of the Pharmacy and Therapeutic Committee, Quality Assurance and Hospital Infection Control Antibiotic Stewardship Committee. Her earlier experience includes working as a general medicine clinical pharmacist at PSD hospitals, where she was involved in ward-round participation, prescription auditing, and monitoring adverse drug reactions. Ma'am's area of expertise include pharmacotherapeutics, pharmacology, clinical pharmacokinetics, pharmacovigilance, clinical research, and teaching and mentoring. She possesses core competences such as excellent communication skills, critical thinking, and the ability to work efficiently in a team. She has contributed to several research works and publications, including a study on the use of fixed dose combination therapy with remogliflozin and vildagliptin in the management of type 2 diabetes mellitus. She has also published research on the assessment of adequacy in estimating time in the therapeutic range of patients receiving oral anticoagulation therapy and the impact of drug interactions. She is currently working on designing and establishing a diabetic registry and is involved in two research projects related to conjugative effects of SGLT2 inhibitors and the evaluation of pharmacotherapy for post-stroke apnea. She has also participated in numerous conferences and workshops, including the first International Congress on Infectious Diseases and a workshop on vaccine pharmacovigilance and adverse event reporting. Now the virtual stage is yours, ma'am.
Am I audible now?
Yes, ma'am, you're audible.
Yeah. Thank you for the kind introduction, dear. And good evening, everyone. Now, right? I'm not prepared with the topic is very important, like your day-to-day life, day-to-day practice. So it's pre dose application, and as we know, what to do, you already know, already heard the classes. So if you want to make so getting the right dose is very important. So I'll show you a few slides so that you can get the idea on that. Am I audible again? Hello? Am I audible?
You're audible, ma'am.
Okay. Can you see the screen?
Yes, ma'am. Even screen is visible.
Okay, thank you. So now I will share you some practical tips so that we can make the calculation easier and safer in our daily practice. So the session overview include it's coming right, the next slide.
No, ma'am. Slides aren't moving.
1 second, let me check. So it's visible now, right? Okay. So in the session overview, I'll go through the pediatric pharmacokinetics, then pediatric dose calculation, then common calculation method, formulas and example, then practical tips, then common errors to avoid. So why do you think the pediatric dosing is different from adult dosing? So as I told you earlier, pediatric is not the miniature adult. The body system is like what to tell the liver, kidney, and they all are developing gradually. And the drug used in children is more complex and error prone due to the variability in size, organ maturity, and also the frequent off-label use. And the dosage must be adjusted on the weight, age, and the body surface area and organ maturity. So we have classified the pediatric like the preterm, newborn infant, infant and old age, children and adolescents. So first of all, the important thing is the pharmacokinetic in pediatric, that is absorption, distribution, metabolism, and also elimination. So the absorption is actually, as you know, at the birth, the gastric pH is neutral and it will become acidic over few days. And also it will again return to the adult level after like the 2 years. So the factors affecting the GI absorption are gastric acid secretion, bile acid salt formation, and gastric emptying and intestinal motility, microbial flora and bowel length, and also illness and the food type. And like I told you, because of the decreased acid secretion after the preterm, the acid liable drugs such as penicillin may increase the bioavailability in neonates, and the weak acids such as phenobarbitols maybe decrease the bioavailability. And also, the gastric emptying is very slower in neonates, which may delay the absorption. And also, the bile and enzymes are immature in neonates, which will lead to the poor fat absorption, like the vitamin D and all. And when go through the routes of absorption, you can see injections are there. So IM injections are not actually preferred because of the the soft tissue, and the transdermal is due to the thin tissue. It is not actually the absorption will be more in that transdermal absorption. You might have heard like recently an incident with a baby, like the mother used to apply something for the rash, for the diaper rashes, and it was something called corticosteroid, some betamethasone or something. So later came to know that the baby developed some puffiness over the face, and also came to know that it's mainly because of the corticosteroid application without knowing. And the rectal inhaled also, rectal is for emergency use only, and inhaled is for technical device development. And when it comes for the distribution, it mainly changes with the age. And more body water in neonates, you know that, right? So it's like 90% of body water in neonates. So the water-soluble drugs such as gentamicin need larger doses. Then it's less in infant. So affect the fat-soluble drug. And the plasma protein binding is very lower. So more free drug in circulation, increasing potential toxicity. And also the blood-brain barrier is immature. So the CNS toxicity risk is very higher. And as for the metabolism, mostly occurs in the liver through enzymes like CYP450. And these enzymes mature over the first few years. And also CYP3A7 active before the birth, and CYP3A4, 2C9, 2D6 start after the birth. And immature metabolism. So the longer drug half-life in neonates. And as for the excretion, kidneys are immature at birth and slower drug elimination. And the glomerular filtration, tubular secretion, and reabsorption all improve with age. And drugs like digoxin, aminoglycoside all need dose adjustment. So, as for the renal elimination, it mainly depends on the plasma protein binding, renal blood flow, and the GFR. Mainly the tubular secretions like age-related changes. So the GFR is 2 to 4 ml per minute at the birth, and then it is like by the 8 and 12 months it will become 120 ml per minute. So here is our topic actually. It's the pediatric dose calculation. So the common parameters used in the pediatric dose calculation are age, weight, and body surface area. And the types of pediatric calculation are mainly like weight-based dosing, body surface area, dilution and reconstitution, and infusion rates, right? So I'll go through each parameter. So in the weight-based dosing formula, you will be familiar that dose is equal to weight into dose per milligram. These are very, very simple slides, okay? So if the dose is like 10 mg per kg and the weight is like 8 kilogram, then it is like 10 into 8 is 80 mg. So the weight-based formula, usually you might have heard like the Clark's rule and the modified rule and all. So these all are the formulas that mainly in the textbook or for the competition exams and all. We are not using these formulas in the daily practice actually. And the next age-based formulas are the Young's rule. So you need to know that Young's rules is not for the infant, and Billings rules and Fried's rules. Fried rules are mainly for the neonates, and the Cowling rules. It's mainly safer and accurate. And the Webster rule is for older children actually. And as for the Young's rule, if the adult dose is 100 mg and the child is 7 years, then dose is like 7 divided by 7 plus 12 into 100. That is age divided by age plus 12 into the adult dose. That is 37 milligram. I think it's clear. And when it goes through the body surface area based formula, that is the most accurate one. And it's named as Mostella formula. So the body surface area we are calculating, as you know, it's using the weight and height divided by 3600. And the dose is child BSA divided by 1.73 into adult dose. That is height is 10 centimeter, weight is 15 kilogram. So the body surface area is 0.7 meter square. So if the adult dose is 500 milligram and the pediatric dose is 0.7 divided by 1.73 into 500, that is approximately 202 milligram. So when we go to the reconstitution calculation, see, it's a problem that a 4-year-old child weighing 16 kilogram is admitted with community-acquired pneumonia, and the pediatrician prescribes ceftriaxone 50 milligram per kilogram IV once daily. So how you calculate? It's 50 milligram per kilogram and the weight is 16 kilogram. So the required dose is 50 into 16, 800. And when you check the vial strength, the available ceftriaxone is like 1000 milligram. So when we reconstitute it with the 10 ml sterile water, the concentration is 1000 milligram in 10 ml, that is 100 milligram per ml. And we need to apply the formula like required volume is equal to desired dose into volume of diluent. So it's like the total divided by the total drug in vial. So 800 into 10 divided by 1000 is 8 ml. That is, we need to draw 8 ml of reconstituted ceftriaxone to give the prescribed dose. So we need to again dilute it in like 20 ml or 50 to 100 ml as per the need. And when we go to the infusion calculation, we need to check whether the unit first, like whether it's mcg per kilogram or like milligram per kilogram. And the stepwise approach is mainly like we need to calculate the dose required and determine the dilution volume and to calculate the rate in ml per hour. So I will discuss the fluid maintenance formula that's called a Holiday-Sagar pediatric fluid maintenance formula. So in the common situation we are using is if a person is child is hospitalized who are in NPO, like nothing per mouth, like the post-surgery or awaiting for any procedure illness. So when the oral intake is reduced but not severe dehydration, and the children on IV fluids for prolonged periods, and supportive care. So for these patients, how we are calculating the maintenance fluid is for the first 10 kilogram, we will usually calculate like 100 ml per kg, and for the next just calculate 50 ml per kilogram. Then for the above 20 kilogram, we will calculate like 20 ml per kilogram. And for example, if the child weight is 35 kilogram, and for the first 10 kilogram, I told you is 100 ml per kg per day. So it's like 10 into 100 is 1000 ml. And for the next 10 kilogram, it's 50 ml per kg per day. So it's like 50 into 10, 500. And next 15 kilogram. So it's 35, right? So it's 20 ml per kg per day. 20 into 15 is equal to 300 ml. So the total fluid per day is, we are adding up all together. So it's like 1000 ml plus 500 ml plus 300 ml. So it's 1800 ml per day. And the rate is, it's like all day, right? So 24 hours. So we are dividing 1800 divided by 24. So it's 75 ml per hour. And what about the syrup, tablet and sachets? So we are calculating it like the ml, that is the volume to give, equal to required dose into volume of suspension divided by strength of the suspension. Okay. Milligram in 5 ml, like 120 milligram per 5 ml is the preparation comes, and the dose prescribed is 15 mg per kg, and I think the weight is like 12 kilogram. So 15 mg per kg means 15 mg into 12. So it will be like how much, like 180 into 5 divided by 120. So it's like 7.5 ml. And I need to especially discuss regarding the amoxicillin clavulanate, because most of the queries coming are regarding the amoxicillin clavulanate, because it's available in different ratios and no one know exactly which one to choose. So mainly for the amoxicillin clavulanate and the cotrimoxazole, you know, right? The trimethoprim and sulfamethoxazole, for those compounds, we are usually calculating the main component. Like for amoxicillin clavulanate, we are taking the amoxicillin, and for the cotrimoxazole, we are calculating regarding the trimethoprim. So the standard dose here is 30 to 50 milligram per kilogram per day divided in BID or TID. This 30 to 50 milligram is exactly for amoxicillin, not for the amoxicillin clavulanate. Here is a common error happening everywhere. So the doctor will calculate and write based on the amoxicillin component, but when we convert, like it's coming as amoxicillin clavulanate, right? So always they will miscalculate and take the all bottom, like what to tell, it will be always the less quantity. And the high dose for the acute otitis media and pneumonia is like 80 to 90 milligram per kilogram per day divided in BD dose. And you need to be careful about the clavulinate limit. It's like less than or equal to 10 milligram per day to reduce the GI side effect. That's the main thing actually. So the ratios coming are like 4:1. It's mainly for the moderate dose infection and some skin and soft tissue infection and bite wounds. And also 7:1, like 400 divided by 400 by 57. 57 is clavulinate here. So for the high dose regimen and pneumonia scientism. Then like extra strength 600 by, that is 14:1. So this is for what to tell, high dose therapy, and it contain only the minimal clavulinate. And when it comes to 2:1, it's like 250 by 125. 125 is the clavulinate here. So that means it's very high dose of clavulinate. So we need to avoid those kind of things. See why we are preferring high ratios like 7:1, 14:1, and 16:1. So the lower clavulinate per amoxicillin dose, fewer GI side effect, allows safe high dose amoxicillin without exceeding clavulinate limit, and maintains efficacy against beta-lactamase produces. So why do you think 2:1 is problematic? Too much clavulinate and it may lead to diarrhea, rash, or poor tolerance. And it will exceed safe clavulinate limit in high dose regimen, and no added efficacy, just more side effects only. So if the child is 20 kilogram and needs 90 milligram per kilogram per day amoxicillin, might be for some higher infection. So it is calculated as 1800 milligram per day. So what if we use 2:1 formulation? So if we use 2:1 formulation, sorry, 250 bar 125 milligram per 5 ml, right? So the volume needed is 1800 divided by 250 into 5, that is 36 ml per day. I'm sorry. Then clavulinate is 125 divided by 5 into 36, that is 900 milligram per day. That means it's far above the safe, like 45 milligram per kilogram per day of clavulinate. It may lead to unwanted side effects. So what are the practical tips? Always use weight in kilogram, like sir told in the earlier session, and double check the calculation. Use standard concentration charts and prefer digital calculators or apps, and measure liquids with oral syringes. So what all are the common errors to avoid? Misplacing decimals like 10 milligram versus 1.0 mg, and confusing milligram with mcg, and using adult doses by mistake, and ignoring maximum dose limit, and also incorrect dilutions or pump setting. So before the conclusion, I will explain about a common error that I used to explain in the CNE and all. So it's actually like a true event. When the doctor ordered a calcium gluconate of 140 milligram, the nurse, something like senior staff or someone who miscalculated it, as she thought like the preparation was come like 10 mg per ml. So for the 140 milligram, she calculated it as like what to tell, 14 ml. But actually the preparation was coming like 100 milligram per ml. That means 1.4 ml. So instead of 1.4 ml, it's for an 8-month-old. I think it's for a baby actually. So for the 1.4 ml, she have given 14 ml. It's double dose, right? And the baby actually, I think baby passed away. Yeah. So it's very important. The pediatric dose and the neonatal dose and all, it's very important, and the risk we need to prevent it before happening. And for the conclusion, see, pediatric dosing requires precision and care, and beta and BSA based calculation are standard. So reconstitution and dilution need close attention and double checking if possible. So But to tell, always double check with your senior or someone if you are not that much confident. So any queries? I know I was a bit faster. Any queries?
Ma'am, when should we use amoxicillin, pure amoxicillin tablets? Means not having a clavulanate.
It's mainly on the higher information, higher infections actually. Like when we don't need the any beta lactamase inhibitors or any that time, we need to use that one, amoxicillin alone.
Because in recent case, I have seen that it was an case of SCD, sickle cell disease with splenomegaly. For prevention
Okay.
of the infection due to encapsulated that bacteria, the prophylactic antibiotic was given as injection amoxiclav 300 mg.
Okay.
Um, so actually the case paper was handwritten. So I have confusion regarding it was amox purely or injection amox 300 mg.
Okay.
Amox clave
Okay.
300 mg because
Usually we won't give like amox like plain. Usually we won't give in like that situations and all. Like it's for the higher infection, like what to tell, crab or something like that. We used to prefer like that.
ma'am, seen in the India Drug Index, then for that particular condition, that preparation of 300 mg was not available for pediatric in 300 mg IV.
Okay.
It was orally. So
Okay.
that.
Any other queries? I can stop sharing, right?
Yes, ma'am. I don't
So,
think that queries now.
okay. Actually, I want to tell you that it's not something pediatric dose calculation is not something that much big. That you need to understand that regarding the formulas that I told you and all, we are only using that in the what to tell in the theory part for the competitive exam and all. We are not using that in the daily practice. So here you need to be more vigilant and like precise calculation and all. You need to be more careful. That's the important thing.
Actually, I
So
am
if
not.
you have any more queries or something like that, you can directly connect into my LinkedIn account and you can directly ask me the doubts and all.
Ma'am,
So thank
why
you.
this is not used in this hospital setting? I am not seen
Sorry.
in any hospital regarding this calculations. As
Yeah,
per
that's
my opinion.
your audio is not connecting, dear. I can't hear you properly.
Ma'am, why these
So you had
formulas
seen
are
that,
not?
right?
Yes, yes. and
Yeah,
not
that's
used.
why because everyone was asking me like where we are using this formula, and they all are like simply by hearting all these formulas. That's why I'm telling we are not using any of these formulas. It's like a milligram per kilogram. What you need to know is like don't treat a pediatric patient as an adult patient. So even today we had a paracetamol poisoning like that. That time the doctor simply wrote the the paracetamol, for paracetamol poisoning, we are giving acetylcysteine as an antidote, right? So the doctor simply wrote like the adult formula and like the adult calculation exactly with the adult dilution thing and all. So, like what to tell, it is supposed to, I will just explain the formula. It is supposed to be mixed in the like 150 milligram per kilogram. Like it is a 21-hour formula. So it's like 150 milligram per kilogram in 200 ml in 500 ml like over 4 hours, then followed by like 100 milligram per kilogram in 1000 ml for the remaining hour. So it should be actually like what to tell. For the kid, it is like they can't we can't give this much fluid to that kid. So it's like a 11-year-old kid. So that is where our role is actually. So we need to tell them that we can't give this much fluid. So it's like 3 ml per kilogram for the first one. So it's like around like instead of 200 ml, it's like 100 ml. Instead of like 500 ml, it should be 250 ml, and instead of 1000 ml, it should be like 500 ml. So that's our role is actually. It's clear, right? I can move on now. So if there is any queries, you can directly contact me in the LinkedIn. No issues.
Ma'am, there is one more query and doubt on chat.
Okay. Yeah, sure. No problem. So what is the query?
The queries, can you explain about TPN calculation, ma'am?
Uh, it's a very big calculation, dear. It's a very big calculation, and I can't explain it over like this. Is it okay if I explain it later?
Yeah, ma'am, there are no issues.
Okay. So thank you, SYCCON, and thank you, Bharat. Thank you for this opportunity.
Thank you, Dr. Josna, ma'am, for that exceptionally clear and practical presentation on pediatric dose calculation. Your role as a clinical pharmacist gives you a unique perspective, and it's clear how your experience helps ensure patient safety. We are grateful for you taking the time to share your knowledge with us, ma'am. Thank you once again for joining with us in this SYCCON Day 16.
Thank you, dear. Thank you.